This is Immunology Unit 4, Lecture 2, Serological and Molecular Detection of Miscellaneous Bacterial, Fungal, and Parasitic Infections. So these are going to be fill-in-the-blank notes, so just follow along with me, and here are your objectives. So first we'll cover bacterial infections. So starting with Helicobacter pylori. This is a gram-negative microaerophilic spiral bacteria that causes duodenal and gastric ulcers. It affects 30% of the population of developed countries and up to 90% of the population in developing countries. Antibiotic treatment is necessary to prevent complications like gastric cancer. Antigen detection procedures include stomach biopsy culture, stomach biopsy urease test, urea breath test, fecal enzyme immunoassays, and molecular testing. So biopsies are not that useful because they're so invasive. If you do the urea breath test, that uses radioactive carbon. And the problem with molecular testing is it doesn't distinguish between living and dead organisms. Another test we can use is antibody testing, and for Helicobacter, we can test for IgG, IgA, and IgM. However, IgM is not worth testing for because by the time testing occurs for an aggravated condition, it's been going on long enough that the IgM might not be present anymore. And although IgG is the primary antibody found, IgA testing may be done in conjunction with IgG testing to increase the sensitivity of the detection of H. pylori. ELISA, immunoblot, and rapid tests using latex agglutination or flow-through membrane-based enzyme immunoassays also exist, but your test of choice is going to be ELISA. Antibody testing does not help with determining if the infection has been cleared because antibodies persist even after treatment, so you have to use other antigen testing like the fecal immunoassay to determine that. Next is Mycoplasma pneumonia. This is the leading cause of upper respiratory infection worldwide, and 20% of hospitalizations for pneumonia are believed to be caused by this bacteria. This organism lacks a cell wall. Culture is difficult and time-consuming, and prior to specific antigen testing, we did cold agglutinin testing. About 50% of patients with the infection have them, and autoantibodies that react with the eye antigens on red blood cells cause their agglutination. The blood specimen for the cold agglutinin testing should be held at room temperature until it clots. The minimally clinically significant titer is 64, and this isn't really performed anymore, especially because other conditions can cause cold agglutinins to form. Currently, enzyme immunoassays, particle agglutination, indirect immunofluorescence, and complement fixation are used for testing. IgM, IgG, and IgA classes are detected. Enzyme immunoassays are the most widely used. Molecular techniques are also available though. And like most things, molecular testing will likely replace serological methods in the future. Next, we'll talk about rickettsial infections. So these are short gram-negative rods that are obligately intracellular. There are two main groups, the spotted fever group and the typhus group. And these diseases are associated with arthropods. So we have Rocky Mountain spotted fever caused by our rickettsia, and epidemic and endemic typhus caused by our felis and our typhi, respectively. These are the most common diseases in the US. So I'll let you guys read some of that. Moving down to here. In the past, antibodies produced against rickettsial infections were detected using a test called the Weil-Felix test. That's WEIL-FELIX, which was based on the cross-reactivity of the patient antibodies against polysaccharide antigens that are present on OX19 and OX2 strains of Proteus vulgaris and the OXK strain of Proteus mirabilis. Current serological assays are organism-specific and include IFA, microimmunofluorescent assays, ELISA, and immunoblot techniques. Because treatment has to be started by the 5th day of illness in order to be successful, diagnosis of antibody production is usually retrospective. And of course, like most things, PCR holds promise for future testing. Alright, so now we're on to parasitic infections. Immunosuppressive drugs used to treat cancer, prevent rejection of transplanted organs, and HIV have increased the number of parasitic infections. Parasites of particular concern for these patients are unable to be diagnosed via routine ovum parasite stool testing. So the first one we'll talk about is toxoplasmosis. Toxoplasma gondii is a protozoan parasite that infects hosts via ingestion of cysts from hand to mouth in contaminated soil or cat litter, or by ingestion of partially cooked pork, mutton, or beef. Cats are known to be hosts, but it is thought that there are other hosts because 24% of the population in the US over age 12 is infected with this. The disease is nearly always asymptomatic, or it may present with mild lymphadenopathy. The organism rarely reaches the central nervous system or the eye, and that typically only occurs in immunosuppressed patients. The encysted organisms can be found in any tissue, and they remain viable for years. But what's important to know is that the greatest concern is that these can cross the placenta, and they can cause death in the fetus if the infection occurs during the first trimester. Serious central nervous system damage occurs during the 2nd and 3rd trimester. Women that have exposure before pregnancy, however, do not transmit the infection to the fetus because they've already developed antibodies. Antibody testing is done to determine exposure, but determining how recent the exposure was is what's important here. So IgM remains elevated for months to years. IgA is detected early but can persist 3 to 9 months. Concurrent analysis of IgM and IgA indicate early infection and are used to screen pregnant women. Elevated titers of any antibody class suggest that the infection occurred within the last 3 to 9 months. IgG without IgM would suggest that you have an older infection. We use EIA, and indirect fluorescent antibody assays are available. Newborns with congenital toxoplasmosis usually have detectable IgM antibody. IgA antibody assays provide even more sensitivity for early detection of congenital toxoplasmosis and should be performed on newborns. And PCR can also be performed on amniotic fluid or CSF in immunocompromised patients to determine if there's been central nervous system infection. So there's a couple other parasite infections that I will let you guys read about. So we'll move on to fungal infections. Of the greater than 80,000 species of fungi that have been identified, less than 400 of them are considered pathogenic. 90% of fungal infections affecting humans and animals are caused by less than 50 species. Some of these exist as normal human flora, although most are introduced to the body by traumatic injury or through inhalation. And fungi grow slowly, so rapid testing is important in diagnosing fungal infections. Rapid testing is especially desirable for undiagnosed acute or chronic fungal lung infections, including coccidioides, blastomyces, histoplasma, and paracoccidioides, all of which can become systemic and damage any organ of the body and are dangerous to culture. The four main fungal infections diagnosed by serology are aspergillosis, candidiasis, coccidiomycosis, and cryptococcus. So aspergillosis is found worldwide in the soil and air and in decaying vegetation and on stored grains. This is an opportunistic infection. Predominantly, infections are caused by 4 species of Aspergillus. Next is candidiasis. This is an endogenous inhabitant of the alimentary tract and the mucocutaneous regions of the body. Testing is complicated because the antigen test can yield false positives due to colonization, and antibody testing can be falsely negative in immunocompromised individuals. Latex agglutination tests can be run with patient serum looking for antibodies, and enzyme immunoassay for Candida antigen is useful in immunocompromised hosts. Next is coccidiomycosis, and this is found in the southwestern U.S. C. immitis is a mold found primarily in desert soil in hot, semi-arid regions. Animals, especially desert rodents, are vectors, and the infectious conidia become airborne in dust storms or earthquakes or construction. You can be asymptomatic and self-limiting if you're immunocompetent, but systematic cases develop an acute primary pulmonary disease resembling the flu that resolves without treatment, and chronic progressive pulmonary disease or secondary infections. The antigen used to identify circulating antibodies in the patient is called coccidioidin. Test methods include complement fixation, tube precipitation, immunodiffusion, latex agglutination, and enzyme immunoassay. Last is Cryptococcus. C. neoformans. Pigeons are going to be the chief vector, and the yeast is inhaled. Cryptococcus may be asymptomatic, or it can develop into systematic pulmonary infections. Untreated, it has a predilection for disseminating into the central nervous system and brain, but it can also spread anywhere in the body. It's difficult to see on a gram stain, and importantly, meningitis occurs in about 2/3 of the patients with disseminated disease. Latex agglutination for cryptococcal antigen is recommended as a sensitive method for detecting C. neoformans in the CSF and the serum. We also have EIA available, which is more sensitive than the latex, but it takes longer. Tube agglutination and indirect fluorescent tests are also used for antibodies. As far as molecular techniques go, they're not really readily available for fungal infection testing yet. They're costly, and they can be used, though, to speciate a mold that's already growing via culture. So that's it for this lecture. I'd like you guys to go ahead and take the quiz that's on Canvas, and I will see you in the next one.